So if a patient comes with mixed edema coma and you give the thyroid hormone first, you just failed the question and potentially killed the patient. So today I will discuss another high yield endocrine emergency, mixed edema coma. Let's start. Who is at risk? An elderly patient, especially a woman, having a long standing, untreated or undiagnosed severe primary hypothyroidism, likely from Hashimoto thyroiditis or post thyroidectomy or radioactive iodine ablation, or patient having poor compliance over levothyroxine replacement. So in these patients, different compensatory mechanisms are already working, like there is peripheral vasoconstriction and reduced peripheral blood flow to maintain the core body temperature and perfusion. So what pushes the patient over the edge? Well, there are different triggers, and infection is the most common. Among other triggers include exposure to cold, like winter months, or there is trauma or surgery in these patients, or there are certain medications like opioids or sedatives, or beta blockers, ramidrone or lithium. These stressors increase metabolic demand and further impair the already slowed systems. The core mechanisms tying it all together, like decreased T3 and T4 in these patients, lead to profound reduction in cellular metabolism across all the systems. Decreased sodium potassium ATPase pump activity leads to increased fluid retention and mixed edema, mucopolysaccharide deposition in the skin that leads to puffy face and hands, dry and coarse skin, and non-pitting edema in these patients. Then, apart from this, there is decreased cardiac contractility, decreased heart rate, and decreased cardiac output, and as well as pericardial effusion in these patients. The hypoxia and hypercapnia, blunted response to hypoxia and hypercapnia together with muscle weakness leads to hypoventilation in these patients. There is decreased gastrointestinal motility and ileus in these patients. And also there is reduced GFR in these patients, and impaired free water excretion in these patients leads to hyponatremia. Now reduced cerebral metabolism together with hypoxemia, hyponatremia, hypoglycemia, it leads to altered mental status. So these are high yield clinical features and pathophysiology in these patients. Diagnosis is based on the clinical features plus labs, but do not delay the treatment based only for confirmation. Write this down in order. First, IV hydrocortisone. First, always, because these patients may have underlying adrenal insufficiency and thyroid hormone increases cortisol demand, and therefore no steroids first means Addisonian crisis. Number 2, IV levothyroxine, not oral, because gastrointestinal motility is dead in these patients. 3, passive rewarming, because aggressive rewarming may cause cardiovascular collapse in these patients. And most importantly, treat the underlying trigger.